Good morning, class. Okay, let's dive into a very important topic today. We're going to talk about a class of drugs you will see every single day in your clinical practice, from the emergency ward to a simple OPD. We're talking about diuretics. So, have you ever stopped to think? Our bodies are absolutely brilliant at keeping everything in perfect balance, right? But what happens when that system gets overloaded? How do we step in? How do we give the body a helping hand to get rid of all that extra salt and water? Well, the answer lies in a very powerful class of drugs. And the answer, of course, is diuretics. Now, the definition is simple, but don't let that fool you. It's incredibly powerful. These are drugs that cause a net loss of sodium and therefore water in the urine. And this is the golden rule. You must remember this forever. Where salt goes, water follows. It's as simple as that. We convince the kidneys to throw out more salt, and the water just tags along. This is exactly why we also call them natriuretics. Make sense? No? But these fantastic drugs didn't just appear out of thin air. No. Their development is actually a fascinating story. So let's take a quick detour, a little history lesson on how we got here. The whole journey began way back in the 1920s with these injectable mercury compounds. Can you imagine? Then in the 50s, things got a bit more sophisticated with carbonic anhydrase inhibitors. But the real breakthrough, the big one, came in 1957 with chlorothiazide. This was the first modern diuretic you could actually take as a pill, a huge deal. But then in the mid-1960s, the superstar arrived, a drug we are going to focus on today, furosemide. And trust me, it was a total game changer. All right, now for any medical student, what is the most important thing? Classification. You have to know where everything fits. Think of these drugs like a toolbox. You need to know which tool to use for which job. So let's map out the main families of diuretics. Okay, look here. This chart is our roadmap, our master plan. You can see the diuretics are broadly divided into three main branches, and it's all based on their power, their efficacy. We have the super powerful ones, the high-ceiling diuretics. Then we have the good, reliable ones, the medium efficacy diuretics. And finally, the specialized helpers, the weak or adjunctive diuretic. First up, we have the big guns, the heavy hitters, the high-ceiling or loop diuretics. Now, why are they called high-ceiling? Because their effect keeps increasing with the dose, all the way up to a very, very high maximum. This is the most powerful group, and this will be our main focus for today. In the middle, we have the medium efficacy diuretics. These are the workhorses, all right? Especially the thiazide group. You're going to see these prescribed all the time for conditions like hypertension. Very, very common. And finally, we have the weak diuretics. No, don't underestimate them because of the name. They have very specific, very important roles, often as supportive or adjunctive agents. For example, the potassium-sparing diuretics fall in this group, but we'll cover them another time. Okay, everyone, please pay close attention now. Let's zoom in on that most powerful class, the high-ceiling diuretics. We're going to focus on the prototype, the leader of the pack, furosemide. This is where things get really interesting. To understand just how powerful furosemide is, look at this number, 10 liters. Just let that sink in for a moment. A single dose can cause a patient to produce up to 10 liters of urine in one day. That's incredible. It's not just a drug, it's a revolutionary tool for managing massive fluid overload. So what makes furosemide so special? Well, first, it targets a very specific part of the kidney called the thick ascending limb. Second, its action is lightning fast. Give it intravenously and it starts working in just 2 to 5 minutes. Third, it has a short duration of action, only about 3 to 6 hours. And maybe most crucially, it is effective even in severe kidney failure, a situation where many other diuretics are completely useless. So the big question is, how does it do it? How does it achieve such a dramatic effect right down at the cellular level? What is the molecular magic that's happening inside the kidney tubule? The magic happens at this protein right here, on the luminal membrane, the NAK2Cl cotransporter. Think of it like a tiny shuttle bus, okay? Its job is to constantly move 1 sodium ion, 1 potassium ion, and 2 chloride ions from the urine back into the body cells. So what does furosemide do? It comes along and just blocks this shuttle. It puts up a big road closed sign so the ions can't get back in. So let's break it down into 4 simple steps. Very easy to remember for your exams. 1. Furosemide reaches the thick ascending limb. 2. It binds to and blocks that ion shuttle. 3, all those ions, sodium, potassium, chloride, are now trapped inside the tubule. And 4, what is our golden rule? Where salt goes, water follows. All that trapped salt pulls water along with it, which is then flushed out as a huge volume of urine. It's a beautifully simple and effective mechanism. Okay, so now that we understand the mechanism, let's bring it from the cell to the clinic. How does this translate into real-world patient care? Where do we actually use these powerful drugs?
Their primary use is in edema, that's fluid buildup, whether it's caused by the heart, the liver, or the kidneys. But their most dramatic, most life-saving use is in acute pulmonary edema. This is when a patient's lungs are filling with fluid and they're drowning. An IV shot of furosemide can literally pull them back from the brink. It's also used for hypertension with kidney failure, for high calcium levels, and even to prevent fluid overload during blood transfusions.
But wait, furosemide has another trick up its sleeve. When you give it intravenously, it also causes the veins to relax and widen. This is called a venodilator effect, and it reduces the pressure on a failing heart almost instantly, even before the major fluid loss begins. This effect is mediated by prostaglandins, and it's key to the rapid relief it provides in acute heart failure. Now, furosemide isn't alone in its class. It has cousins, bumetanide, and torsemide that you should know about. Look here, bumetanide is about 40 times more potent, and its oral absorption is excellent, which is a huge plus. Torsemide is also more potent than furosemide, and it has a longer duration of action. The choice between them always depends on the specific clinical situation.
So we have these incredibly powerful drugs that can force the body to shed so much fluid, but our bodies are smart. They don't just give up control that easily. Which leads to a crucial question for you all to think about. What happens when the body starts to fight back? That is a topic for another time.